I was part of the surgical course today, and I was addressing the topic about neoadjuvant chemotherapy and the Karolinska experience. So that talk was based on the fact that neoadjuvant chemotherapy is increasing, and we have a national breast cancer quality register, so we're able to catch all patients being operated on. And I presented the results from a register studies made by 2 medical students, supervised by colleagues of mine in oncology and in breast surgery, and looking at both the rate, firstly, of reoperations after breast conservation as a final procedure, and finding out that this is quite low, like 8% of cases were actually had to do a second operation. And we also presented data on the evolution of, I think, treatment for breast cancer, who was in the 70s mostly surgical, mostly mastectomy. Then with the introduction of breast conservation, we saw a change in the occurrence rate quite late, actually in the 1995, to see that breast conserving therapy was becoming more prevalent than mastectomy. We also have seen a dramatic change in the use of adjuvant therapy, like chemotherapy, that was given to quite a low proportion of women or patients at that time, and now is given to about 40% of cases in Sweden will receive chemotherapy. Endocrine therapy is, of course, to all cases where we have receptor positivity. So that level is quite high, because half of our cases are stage 1 small tumors, and we can also see that 85% roundabout will actually keep their breasts. So we have quite a specific panorama of early breast cancer in Sweden. We then looked at a series of around 1,000 cases having had neoadjuvant chemotherapy, with a goal to see how many of these patients could actually preserve their breast, because that's one of the goals of neoadjuvant chemotherapy. We also looked at time trends, and if there was anything in tumor biology that would predict the possibility of preserving the breast. And so what we found was, of course, that in the later time trends, there was more breast conservation being done. So looking at from 2015 to 17, like 40% of the cases actually had breast conservation as their final procedure. We saw that, of course, it's more directed towards tumor biology, smaller tumors, offering this kind of treatment. And we also saw that the HER2 positive cases, triple negative cases, were more likely to receive breast conservation. We also had the possibility to briefly look at local recurrence, because we do know that survival figures between neoadjuvant and adjuvant are almost non-existing, but quality of life is also a very important issue. So we found that there was a very, very small difference, however, in favor to breast conservation after neoadjuvant chemotherapy. We can also debate what are the factors to more deem the success of the procedure. Maybe the radiological appearance is quite important to see that you have a complete response, and when you operate that you do not find any viable tumor, neither in the breast or in the axilla. I think we've already seen the tremendous increase in neoadjuvant chemotherapy because the aim is to convert locally advanced breast cancer into treatable breast cancer, to be able to monitor the effect and to be able to change regimen if you don't get a response. So I think that's where we're going, and I think the conventional setting of having chemotherapy at the end was that surgery was a dominating procedure. But now when we are more directed and we have more information about tumor biology already from the start, from our core needle biopsies, we can be more tailored to what kind of treatment we are actually going to recommend to the patient. And we are also being in the possibility of monitoring that with patients' outcome, looking at baseline data and also following through. Because as I said, survival figures are likely not to be very different, but local recurrence is also something extremely handicapping for any patient who suffers from that. And has also, of course, an impact on survival at the end.